we are, many of us are connected here to the School of Public Health or to other academic units at the University of Minnesota. So I want the first question for our speakers to discuss to engage with the question of education and training. So you each described really innovative visions and important visions for the future of public health, with, as we just heard, was also the history of public health. But how do we make sure that our students now are going to be ready to make the changes that we need in the future? What are the specific skills and capacities that they need, and what type of courses or experiences do we as faculty members need to give them?
So I'll jump in, Sarah. Thank you for that question. One of the things that we did at Johns Hopkins Bloomberg School of Public Health a few years ago in our strategic planning was to identify future areas of growth for public health, and health impact assessment, HIA, was one of those areas. And so because of my work in the area, I developed a course, and I teach one of the few courses in the country on HIA at an institution, and we developed a model curriculum, which Sarah mentioned in my introduction. And so if you're interested, we can definitely share that resource. But in doing that review, we learned that there are many schools around the country that have lectures on health impact assessment, but there were really only a handful of schools that actually teach students how to do that. So in our class, we work with our local health department and nonprofit organizations, and the students actually go through an HIA. They learn about how do we work with the community to scope issues, how do we engage with them and hear about their concerns, how do we do a stakeholder analysis. So they're learning all of those skills that are part of a health impact assessment. And we also teach broader issues around health and all policies, around policymaking, equity, and we're seeing that in some of the other programs across the country that actually have this course. And in some institutions, that course is cross-listed between public health and planning and other types of schools. We don't have those other schools at Hopkins, and so my course is situated in our health policy department. That's just one example of how we're training our students.
Thank you. And from a perspective of community organizing, I'm sure students here would like to know how they can learn those important skills as well.
Sure. So we do some cross-training with public health professionals where we'll have leaders in the community and organizers learn about public health in the field, and then have public health professionals learn about organizing. So it'd be interesting to think about incorporating that into some of the classes here as well. The other thing that, so I went to graduate school for public administration, and I don't know that I took a single class about how public decisions are actually made, how power operates, and how communities can actually influence that process. So the more that we're actually looking at the real raw and no rose-colored glasses, how things actually around, how decisions about resources actually happen, and understand that, and face that reality, people will be more equipped to interface with community organizing.
Well, my perspective is if we're going to really actually change how the students learn, I think we have to increase the minimum wage. We need to have a living wage. Kids will not be successful in education unless their parents are economically stable. I think the best thing we can do for third grade reading is probably have safe and stable housing for everybody. That's going to change people who are going to graduate from high school and actually go into college. We need to look at all those policies, not just what happens with the people when they get to the university, but who comes to the university, who has the opportunity to do that. And so I think we have to always reframe that what's the pipeline, what's the environment that gets people there, and it is all of those social policies. And then I like to use the quotation from William Butler Yeats, that education is not the filling of a bucket, but it's the lighting of a fire. And we do so much in our education to just fill up buckets with lots of information. That whole common narrative that education is just about job training. No, it's about actually enhancing people's ability to learn, about people's ability to dream, about people's ability to engage in communities. So we have to really look at how we can use education to give a broad array of skills and allow people to really dream about the future, because the other quote from William Butler Yeats, in dreams begins responsibility. And when people can dream about what they want to do, they actually have some responsibility. And then they will go seek out the information that they need, and we have to allow them to seek out the information that they need to make a difference.
Thank you. Well, I'm swamped with questions here, but I want to focus with one question. Someone in the audience wants to better understand the concept of structural racism and ask Dr. Ellinger to please give some examples of structural racism and what that means, because that may not be a term that everyone's familiar with.
Yeah. Structural racism is when a policy is in place that disadvantages a population of color or American Indians. And it's not about individual racism. And it's not about intent. It's about the outcomes that occur. And it happens all the time. We were a population of mostly white folks, and so the policies were put in place over many, many years that made a whole lot of sense. A lot of times they were based on economics, but they weren't based on equity. And so even within our organization, we looked at some of our policies. So we do radon protection, reduction in testing. And so, radon, a cause of lung cancer. So we looked at our policies, and actually we targeted for our educational approaches home ownership. Very efficient way of getting information to the people who own homes. Not recognizing that only 21% of African Americans own homes and 75% of whites own homes. Unbeknownst to that is structural racism. That's when that policy structurally disadvantages one population over another. So we're looking at all of our things. We're looking at how we do our grants. Our grants, because we're state agencies, we have to be good stewards of our resources, so we want to make sure that every agency that gets grants from the health department knows exactly what to do with those funds and will not misuse them in any way, shape, or form, and can tell us exactly what they're doing with them. That disadvantages organizations that are just getting started. They're disadvantaging organizations that are really run by people from other countries and other cultures. So that is a form of structural racism. We're trying to be good stewards of resources and not break the law, but in doing that, we structurally disadvantage some populations. That's structural racism. It's prevalent all over. There are many other examples, but that was just a couple.
Thank you. So we've got a number of questions about the sort of current model of health funding, which is not sustainable and also doesn't support the type of initiatives that we've been talking about today with regard to the social determinants of health. So one person asks, for any panelist, when do you foresee that public health funding will be more aligned with the social determinants of health? And how can we see that change from the of our 5% that goes to public health, 95% goes to Medicare, and even within public health, we don't see public health funding going in this direction. So I'll start with that, but I have a part B to that as well.
I don't want to answer all of the questions. First, but I will start because they're thinking there, their eyes roll back. We have to change the narrative about what creates health. And we have to allow communities to be part of the engagement process. So we're trying to do that with our SIM grant, our State Innovation Model grants that we've got from CMMI, from the Medicare and Medicaid agency, where we're taking the medical piece, which we've been working on ACOs, and then embed those medical organizations within the community and then give community ownership about how the dollars are invested and partnering with public health and human services. And so that's where I use the example of Boynton Health Service and on this campus is a good model of where the student fee committee collected taxes from the students, that's the fees, and they decided where to invest. And so one year when I was here, I said, we need to hire a primary care doc because our clinics are busy. And the students said, our biggest need right now is transportation on Thursday, Friday, and Saturday nights because it's unsafe. Because I'm sure they were going from the library to home, but it was unsafe. And they said, you at Boynton, hey, you have the infrastructure to run a bus service in the evening, so we want you to do that instead of hiring a physician. So we did, and guess what? ER visits went down, urgent care visits went down, visits to our clinic went down because the students knew better. So they get to invest in rec sports or in student unions or cultural centers or the student legal service or parent. They get to decide. When the community decides, they certainly do a whole lot better job of that. So part of that is to change the narrative about what creates health. And then we need to get the communities engaged. And certainly in the legislature over the last several years, we as a state health department could not go and ask the legislature for some more money to work on advancing health equity. The community actually came forward in many ways and said, legislature, you saw this health equity report, you need to do something, we think you should fund, and then they funded last time, $500,000 worth of stuff, small potatoes, but a step in the right direction because community got engaged and advocated for it.
Were you going to say something?
I'll just say something quickly. So I was thinking, not knowing that much about the allocation of health funding, but realizing that there's some accountability on us for this work. So it's not hard for people to understand that working 2 jobs or the violence that they face or the constant stress is impacting their bodies. But what they have maybe less imagination for is the role of public health and the role of our state and city and county governments in altering that. So part of our work is to advance this narrative about health and what people are up against. And it's not just about ability to go to the doctor, but it's this whole spectrum. And then being in relationship with the public health department to begin to imagine more and more what can we collectively do together.
And I'll just add, in addition to changing the narrative and engaging communities, I think it's holding our decision makers accountable, right? And so the people that we have who are running our agencies, who we put in office, how do we help them to rethink how they are doing business? I mean, I love the comment you made earlier about when we approach our new political cycle, what are our candidates talking about? How are they talking about health? Is it just about how much money we're giving to insurance companies and hospitals? No, it's broader than that. And how do we change the dialogue? I think that there's some opportunities, as we'll see, with funding around doing community health needs assessments. I'm on the board of a local hospital, and our narrative has changed over the last few years because our readmission rates are tied to our funding. And when we look at readmissions, what do we see? We see that people are coming back to the hospital because of those issues related to social determinants of health. So now we're writing more grants, we're working with community partners, we are building coalitions around how do we address those social determinants of health to ultimately reduce the readmissions, improve our readmission rates, to then in turn improve the community that's being served by this particular hospital.
Okay, so I have a question that I think Kate can best address moving into, so we've talked about kind of the big picture policy and funding, but down to the community mobilization piece. And this is a question, what should white allies do in the interest of working with communities of color, but who don't have the background or knowledge on systemic racism, and who enter the public health field with potentially a superior mentality, AKA, I'm here to help the poor. So can you talk about that mentality?
That's a lot. We could talk
Sorry.
for a while.
These are great questions, everyone.
Okay, so number one is deep humility. There is a professionalization that happens to people where being an expert becomes your primary role. As a white person, you're not an expert on what people of color have experienced. You are not, and you will never be. So willing to be wrong, deeply listening, deeply believing people when they tell you things. That's where I would start. I also think every single human being, when you're working towards transformational change, needs to be able to articulate your why do you want this? So you don't want to just operate in a charity space, but why are you, as an individual person in the world, in this interwoven fabric together, understanding that my fate is tied to yours and that I really care about this work because of my own experience. So there's a tendency sometimes for white allies to take themselves out of it, which is the opposite path of building trust and vulnerability and real relationship with other people that are not like you. That's where I'll start.
Yeah, thank you. A set of questions concerned our interest in paid family leave, paid parental leave, paid sick leave here in Minnesota. So I'll ask one from Twitter. Thank you. Have other states that passed paid family leave, California, New Jersey, or Rhode Island, seen a reduction in infant mortality in communities of color?
I don't think we have the information yet. There's certainly one of those things that needs to happen. We do know, just from the literature, that it does that. From the studies that have been done, I don't know about those states in particular, but paid leave, paid sick leave, and paid parental leave actually reduces infant mortality. Yeah. And it particularly impacts populations of color, because those are the ones who don't have access to it. So generally, and when you have mandatory, those are the groups that benefit most from it.
Okay. Well, it sounds like there's a pretty interesting master's project or dissertation topic out there to look at that connection more explicitly. And another question about paid leave just concerns the political climate. So how can paid leave even be discussed in a nation where comprehensive maternity leave is not on the table? And how can we move that conversation through a health impact assessment approach?
Oh, Kate, start with that one.
Can you repeat the last part of it? How can...
So the question concerns that it seems like, wow, we're in a political climate where there isn't even any kind of paid parental leave on the table. So how can HIA specifically help make other types of paid leave, whether sick leave or parental leave, be possible? What might that process look like to connect HIA to paid leave policymaking?
So I think like any of the HIAs that we would work on, that we really believe in this muscular connection between serious research and then serious community power and advocacy. So that would be true here too. My understanding of paid paternal leave is that it's incredibly popular across the political spectrum, which means there's a small amount of people in power that are blocking it from happening. So the goal of a health impact assessment would be both to advance the short-term and long-term impacts of having those policies in place, but also to build more and more community infrastructure to advocate that and frankly, from our perspective, go up against the power that's in the way of something that's incredibly popular.
And I'll just say quickly that there are examples of health impact assessments that have been done around these issues. And if you're interested in looking at those, that map I showed you earlier, it was created out of information collected from the Health Impact Project. So if you go to that website, there's a searchable map there, and you could search by sector, by topic, by state, and look and see how has HIA been used to look at the health effects related to paid sick leave and look to see, well, who was engaged in that process. Clearly the politics have sort of thwarted some efforts there, but I do think that if you're looking for some good examples, that's one thing. There's a legislation moving through Maryland on paid sick leave, and they've looked at those health impact assessments to try to make those connections. How do we connect this to health and show that there are benefits for everybody, the private sector, for the public, and it's really a way to address the inequities in our state.
And really, paid sick leave is not about them, it's about us. We all benefit from paid sick leave. You know, the people who are least likely to have paid sick leave are service workers who are taking care of the people in hospitals and nursing homes and serving us food. And many of the foodborne outbreaks are because people have come to work because they're sick because they can't afford to lose their job. We also know that people actually leave less time away from work when they have paid sick leave. It's an economic indicator that businesses need to recognize that it's really beneficial to them. So most of these things are about vested interests. We start to recognize the narrative that the vested interests that people have are actually advanced by some of these more progressive policies that advance health equity.
Okay, there's now a number of more specific questions about conducting HIAPs and HIAs. So for Keisha, can you give examples of inner city or interstate HIAs or transboundary HIAs, or does it usually happen at the level of a local sort of policy-making structure?
Yeah, good question. So HIAs have been conducted at the local level, state level, even regional level decisions, and federal level decisions. I think a good example is one that we've been working on now, looking at HUD and some policies they have around designated housing, right? And that's something that affects everybody all across the country. And so that HIA we've been working on at the Health Impact Project for some time, and that will be released hopefully this summer. And we've been really starting to look at issues that are crossing over states' lines. There's also been HIAs looked at regional distribution in terms of sustainability and looking at agricultural types of issues, so we've seen those as well. Again, I'll direct you to that Health Impact Project map for examples, and you can search and identify HIAs that have been done at the regional level, state level, federal level. It's a tremendous resource.
Thank you. Another more specific question directed for the Commissioner is MDH has many different functions. Where does the Health and All Policies work fit in within MDH? And are there specific units that are focusing on HIA and HIAP?
Well, just like health equity is not, we have a Center for Health Equity, yes, but health equity is core to everything that we do within the health department. So it is part of should be part of every program, every issue, every unit, every division within the health department. And the Center for Health Equity is there just to support their work throughout the agency in advancing health equity. Similarly, with Health and All Policies, we are educating our staff and talking about how policies in all areas, really, and with our partners, that those things have impacts, health impacts. And yes, we have a unit that really focuses on the expertise of developing the technical expertise of health impact assessments. But again, it's with our community engagement efforts, getting it out into the community so it's being used in a more broad fashion.
Okay. And then the last HIA-related question concerns training. Beyond students, so yes, we can implement curriculum, and I hope that we look into that very carefully here at the School of Public Health to give HIA training to our students. But outside of that, how do we train decision makers about HIA, whether how to do it and how to understand its utility?
I'll just give you an example of my work. I think it's critical to train decision makers and policy makers also. I've been invited to speak at forums put together by the National Conference of State Legislatures where I've talked specifically to legislators about HIA and how it can be used for policy making and giving examples of how that's been done. I'll put a plug in for the 3rd National Health Impact Assessment meeting happening this June in Washington, D.C., the 16th through the 18th. And at that meeting, we, in the past, both have had over 400 attendees, and we have individuals who are new to health impact assessment. There's a HIA 101 track where you can go and learn, and we actually do targeted outreach to decision makers and policy makers to attend that meeting. I'm organizing a particular meeting with members of the National Prevention Council. We've been doing a lot of engagement at the federal level with decision makers to say, well, how can our federal government use HIA and HIAP to make better decisions? And so we are slowly, we at the Health Impact Project, working with partners to really expand our reach, to engage with practitioners and decision makers and policy makers across the country to learn more about these tools, to, again, change the narrative about how they're talking about health, understanding the connections between social determinants of health and health outcomes.
So each of the speakers today talked about the important role of the community and community involvement, but we've had some questions concerning specific types of communities here in Minnesota and across the country. Here's one question that I think is very important. The multicultural community feels very burnt out with all of these professionals, health or not, who come into their environments to be surveyed, questioned, et cetera, to gain input on specific projects that may or may not even be of interest to them. How can we build capacity in the community to partner with professionals to have a voice against people of power? We need to give the community an opportunity to have a voice and not for others to speak for them.
I didn't know this was a thing until I started organizing. And I started organizing particularly in the African American church and with other communities of color that they said, as I was building relationships with them, you're not coming here to study us, right? No, it's not my job. It's not my job to speak for you or any of that, but it's a regular and routine thing, which is why I was trying to make a distinction between engagement over organizing, which engagement tends to be a one touch for the project you want to work on, can be really important, but it is a very different enterprise than people organized around what they want and need, advancing their own interests. So I don't know entirely what the solution is, except at least the first step is to be aware that this is happening routinely to people, in sometimes very, at best, disrespectful ways, and out of relationship with where people actually are in their lives. And that I do believe that we can actually have strong, real relationships grounded in organizing with communities and institutions, but they need to be negotiated. Power differentials need to be understood, and that tension needs to be regularly experienced.
Yeah, what you're talking about is the traditional data colonialism, where you come in and mine data and then leave, and there's a big hole in the community. And I think the questions that I raised, the 3 points in my presentation are the questions. Who's at the table? Who's got the power at the table? Who's making decisions? I think those are the questions that need to be asked about the processes and the policies related to research in communities. Communities need to be at the decision-making table about what research gets done and how it gets done.
And I'll just say one last thing, too. Kate's comment made me think about for our HUD HIA, we went back to all the communities that we went to collect data, and people were so surprised. And they said, I can't believe you came back. And I mean, how many times do those of us in this room do work out in the community? We never go back and share our findings. We never go back and tell the story of what we heard in a way that they can understand. And then possibly use those data for future advocacy efforts. And so I think that that's part of it as well, holding ourselves accountable when we are working with the community to make sure that we are not just collecting the data, writing the paper, and walking away.
And actually, it's beneficial. The research gets done better. I mean, even though our Advancing Health Equity report, I wouldn't really classify it as research, the process was really informative to us because we did not do a draft of the Advancing Health Equity report based on all of the data that was out there. We actually said, let's go out to the community and ask what they're finding, what they're seeing, what issues they have, and then took all of those words from those thousands of meetings that we had and wrote up our Advancing Health Equity report. Then we went back to the community and said, do you hear your voice in this report? And if they did not hear their voice in the report, we went back and rewrote it until they heard their voice in the report. That has changed the relationship that we've had with communities of color in particularly because we really tried to get their voice in there and worked with them to get their voice in there. And that has made the report much more powerful than if we had just done the draft report and then just got input and then redid it based on that input. It was really an iterative, collaborative process that made it much more powerful.
And there are two questions asking for specifics about two particular communities here in Minnesota and what their role is and how they've been at the table. So the first is that Minnesota has the highest number of African immigrant communities. What specific efforts and programs advance having African immigrant leaders at the table and decisions affecting their health? And a very similar question came in from someone else asking about the role of American Indians in achieving health equity in Minnesota. If you can comment on those two communities.
Yeah, boy, it's tough. Immigrant community, actually, when the immigrant communities come in, they're actually healthier, and so we have this healthy immigrant effect. In fact, African American, well, the births to U.S.-born black women is twice that of African-born women, infants of African-born women. So there's a healthy immigrant effect. So we have to really try to maintain that. But what I've been really seeing, I've been really focusing really on I've been watching the Somali community. And what I think the Somali community is educating us about is that they are actively getting engaged in policy. They are actively getting engaged in community organizing and development. You see some Somali leaders actually in city council and on school boards. They're learning the system of how to do policy and community organizing. And I think that is one of the ways we got to get them to do that right away. The American Indian community is a very difficult one with the historical trauma that they've had here and the centuries of discrimination that we've had here. We don't have I don't know exactly the way to do it, but what we are doing is we're listening. So we've had tobacco control grants on the reservations, and they've not worked because we've said, well, these are best practices, and the American Indian community says they're not best practices for us. So we're going back and say we have to start over. Tell us what is best practice. How can we work with you to do things in a different way? And then how should we evaluate it? We need a lot of learning with the American Indian community to really be able to make more progress. And I think respectful listening and active listening is one way to do that.
Okay, great. And a third question came in also asking to comment on the immigrant Asian populations as well in our community.
Same thing.
I don't know. Certainly what we... One of the ways that we traditionally do this is workforce development. We're trying at the health department to get our workforce to look like the populations that we serve. And a lot of times we just look at the top level and, who do we get in as leadership, and that's important, but we have to work from the bottom. We need to develop entry-level positions for people and then develop from the inside. And that's where I think also looking at our whole educational system and how we get people in. This is a long-term way of advancing equity by really empowering people through education, through employment, through communities.
We've received a couple questions about the framing and the use of the terms that we use in talking about these kind of rising policy tools. One question concerns when we use the word health equity, which seems to be the word that's in vogue now, why aren't we using the term racial equity as much? And the other question related is why do we say health in all policies and not health equity in all policies if equity is at the center? So asking about reframing these terms.
So I'll reframe a couple things. Just one is that some people just don't like to use the word equity. It has, in my conversations with health commissioners in other states, they can't use the word equity because it is, it's like the ACA. It's just one of those flash words, and they want to use advancing health for all or optimal health for all. But I think equity is the word. It connotes a whole lot of other things that really are important to get at. And whether it's health equity in all policies or health in all policies, I'm agnostic about that. Health equity has to be at the core of everything that we do. We work in the field of health. I think health is central to everything that happens. So health equity actually gets at equity in all other kinds of fields. But I can go any direction with that.
Yeah, I equally try not to get caught up in the phrase there because it's the goal. What's the goal? I have colleagues who've said to me they can't even use the word health impact assessment in their state because of the challenges around environmental impact assessments and all the history of that and what does that mean. And so people have said to me actually, well, the field should actually change the name. They shouldn't call it HIA anymore because when people say that, there's this visceral response to environmental impact assessments. And I think those challenges are real, and as part of framing, I think it's important to then go back to the goal. What are we trying to accomplish? I similarly am agnostic around whether it's the health impact assessment. There are people who sort of talk about doing equity impact assessments, and there are all these impact assessments that have developed over the years. And I think, again, for me, it's what's the goal, and if we're doing a health impact assessment, is equity central? Are our recommendations around addressing the inequities? And as far as the comment about sort of racial differences or equity or health equity or racial disparities, I think for me, it's a reminder that equity is beyond racial and ethnic disparities. There are inequities in terms of gender, in terms of religion, in terms of these other factors that we care about, anything that sort of hinders somebody's opportunities to advance their life and to live their best life possible. And for me, that's not just an issue of around race. There are all these other factors as well, critically important, particularly as a Black woman. I live that often, and so I just wanted to just comment on that point as well.
So I don't know why any of those names are used. And I haven't sometimes seen health equity as used as a way to avoid talking about race explicitly. I haven't seen that from MTH at all. What I saw with the Advancing Health Equity report was an explicit naming of structural racism, was Commissioner Ellinger publicly going around saying structural racism is a key impediment to the health and future of our state. So what I've seen is health equity has been a good framework to talk about race in our state.
But we have to acknowledge that race is one of the hardest things for us to talk about. So that's why we do focus on it, because it's so easy, particularly for people in public health, to say, well, it's not just about race, it's about income, and it's about education, and it's about, yes, it's all about all of those things, but it keeps us from focusing on some of the racial issues that are the hardest ones to talk about.
Okay, I think I apologize in advance. I haven't gotten to every question. I want to end with one question, and then we'll wrap up. So this question concerns the need to change the narrative, and so trying to change that narrative about how we talk about health, and particularly how we get decision makers who generally have more power and more privilege to do that. So the question asks, specifically, what data and evidence has been effective in changing the narrative among privileged decision makers who may not see the connection between their health and that of less privileged individuals? So I guess in other words, one question I have, and I think that reflects in this question, is, can you give an example of that aha moment when a decision maker with privilege, with power, recognized the importance of health impact assessment, health equity, or health in all policies?
While I think about that, I don't know, did you see that article in the paper the other day, Variety section, about automobiles in our love affair with automobiles? And it highlighted the fact that in 1961, automobiles were causing some major problems in the auto industry because we had it related somewhat to the Rondo expression that where they had talked about white roads through black homes, and people were questioning, well, do we really want to do this interstate highway stuff and cars? And so they had a marketing campaign about the U.S. love affair with automobiles, and it changed the conversation almost immediately. You could almost focus on that one advertising campaign. It changed that narrative. And all of a sudden, we have a love affair with automobiles. That hadn't been that way prior to 1961. So that was an issue that we saw a change in the narrative fairly quickly. I think what we're seeing with health equity, it is a constant repetition of what's happening. The data are really important. I think when I go around and talk about showing that pie chart that it's only 10% medical care, people, and then they get it because it's intuitively obvious, but they had not thought about it before. And then when the community comes and reinforces that along with the people like myself in the healthcare field, and then when policymakers start seeing what an health impact assessment actually shows when you get an example of that, they say, oh, it's one little light bulb after another. It's, it's probably that Christmas tree where one bulb goes on at a time as opposed to all occurring on at one big blast.
Okay, thanks.
I'll say for me that an aha moment came a few years ago when we were working on our SNAP health impact assessment. During our work, before we did our assessment, when we talked with decision makers on the Hill, we asked them, what sort of data, would you like to see in this if we could sort of do that? And many times individuals said, well, what's the cost data? Show us the economics. What's the economic argument? And I remember when we finished our report and we were going back to do outreach and stakeholder engagement, we were sitting in an office of a very conservative member of Congress, and we showed, our analysis showed that there was a proposal that was proposing to save $20 million by making certain cuts to SNAP. And our analysis showed that those same caps actually could cost shift the amount to $15 million in Medicaid costs. And that was an aha moment where it was visible, and the person said, I didn't realize that. It was really powerful in that moment where it was clear that the proposals to save those resources are going to have these downstream effects that hadn't been thought about in a systematic way up front. So that was one way for me where we used the economic data that people wanted in a way to help them see the issue a little bit differently, and that the fact that they were seeking cost savings actually would have other implications in terms of cost in other sectors.
So I'm struggling a little bit with this aha moment because I do believe that I wish that the data and research and everything that Commissioner Ellinger laid out was enough to change people's minds, because the data and research on health is on our side. Like, we know what people need to live full and dignified lives. So the aha moments that I've seen in my life have been more of a combination of all of the facts and the data, and then the human beings with the stories that are engaged collectively in trying to advance something together. That's when I've seen aha movements, which is power, essentially. We're trying to shift power. And that's where I've seen decision makers, both in their hearts and guts, move, but also see, like, I have a whole set of voters and constituents that really, really care about this.
And you have to do it one at a time. I've been, I got all of the commissioners to sign on to our Advancing Health Equity Report, but over the last 4 years, I've systematically asked every one of the health commissioners to come on my TV show to talk about their impact on health. And it forced them to think about it. If they're going to be on TV talking about the impact of commerce on health, the impact of economic development on health, they have to think about that for several weeks. And when they come on and talk about it, and they're saying some things that are out there in public, it was part of the strategy to get them to think about their part of the public health workforce.
Okay. So thank you. It's time. I have a few observations that I've made from this really exciting event. Also, I just want a little bit of housekeeping. Please fill out your evaluations and return them to the registration table in the back. So as we reach the end of this Public Health Week, we're celebrating our successes in public health and improving population health, but we don't want to stand our ground. We want to continue moving forward and making progress. And what we've heard today is that to do so, we're going to have to make a lot of changes. to see difference, or else we will find that our relative differences across groups in health outcomes and health indicators could threaten to widen. Achieving that health equity vision is going to require change in our huge institutions, in state agencies, in the legislature, in our academic institutions and educational institutions as well. And it's also going to require accepting truths that can be really hard to swallow, like the role of structural racism and the role of policy in reifying and creating the disadvantage that we see today. I think also a health equity approach is about being very explicit about recognizing the interconnections. So the quote that Dr. Ellinger presented about whatever affects one directly affects all directly. But what appeals to me about an HIAP and HIA approach is that it implements that vision, but makes it not about rhetoric, but about a concrete set of skills and capacities that we can use to make those connections and advance policy change. And finally, I heard, particularly from Kate, that to be motivated to make the change that we need to make, we have to have pressure from citizens, community members, and leaders alike, and that we all need to play a role, everyone here, in reframing and retelling our narrative about health. We can't continue swimming in our separate lanes or remaining in our silos. And I want to thank Dr. Ellinger, Dr. Pollack, and Ms. Hess-Pace for showing us a path for doing so, for doing that hard work. And please join me in thanking them for this discussion.